of you who have joined us, and welcome to the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. We thank you as always for joining us. Please note that you have been placed in listen-only mode. So if you have any questions during today's presentations, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. The slides from this webinar, as well as a recording of the event, will be made available on the provider page of our website by tomorrow afternoon. Additionally, today we will be issuing several live interactive polls, very quick, to gauge your feedback during the presentations. So we thank you for your participation in those polls, as well as in a final poll that will be issued during the last 5 minutes of today's event. Today we're joined by Dr. Corinne Thompson, co-lead of the Epidata Unit for the agency's outbreak response, Dr. Jane Zucker, branch director for the vaccine section of the agency's outbreak response, as well as the assistant commissioner of the agency's Bureau of Immunization, and Dr. Pooja Jani, health systems planning and strategies lead for the agency's outbreak response. So we have a packed agenda today, and with that, I will pass it off to Dr. Thompson, who will provide an overview of recent epidemiology of COVID-19 in New York City.
Can you hear me?
Yes, we can hear you, Doctor. Thank you.
Wonderful. Can you allow me to share the screen? Is that okay?
Yes, working on that now.
No worries. Thanks. Okie dokie. So hi everyone, my name is Corinne Thompson, as mentioned, and I'm one of the epidemiologists here. So I just want to go through some of the latest epi quickly, and then I'll also touch on variants and what we know about them in New York City. So it's been a while since I've been on, so just to orient everyone, hopefully you all know that this is the New York City COVID data webpage. And before I go through the sort of most interesting points, I just want to note that you can download all of our data and technical notes on GitHub, which when you click this link, it brings you here. And we have all of our data, actually just updated it 8 minutes ago, and we have lots of documentation and all of our files that you can download every day at 1 o'clock. So overall, everything is trending in the right direction. We have all of our cases are going down, hospitalizations going down, and deaths are also going down. So the epi curves are really wonderful, and so we're feeling sort of a sigh of relief, as I'm sure you all are as well. So you can see here, this is cases, hospitalizations, and deaths all trending down nicely. And then percent positivity also trending down, although this is sort of still a scary red color. The maximum here that we're seeing is 2.9%, which is much, much better than what we were seeing even a couple of weeks ago. And by different zip codes here, you can sort of sort by the highest to the lowest and sort by the kind of count of new people positive. And even the highest, as mentioned here, is 2.9, but it very quickly falls off from there. So we're very, very pleased to see all of this. Well, I will say that testing overall has started to go down. So in this graph here, you can see the number of people tested by PCR in blue by day, and then the number of people tested by antigen in gray by day. And we're at about now 40,000 people tested every day, whereas at the beginning of June, we were at about 50,000 people tested per day. So we are seeing a slight decline, which makes sense as people are vaccinated, less need to get tested all the time. And I think that is pretty much, we are seeing an increase in 0 to 4s for ED visits for CLI-like illness, although the percent people, the 0 to 4-year-olds who do test positive for COVID is still quite low. And then this is admissions, where everyone is still quite low, which is good. I also just want to quickly talk about variants, which are for some slightly confusingly, sorry, just want to get here, on a different area of the website, which we're hoping to rectify shortly. So this is on the main COVID-19, New York City COVID-19 website. And if you click, which is this link here, and then once you click that, sorry, you'll be taken to 2 different bits of information that, again, we're hoping to make much easier to understand shortly. The first is a summary of the recent what's called GISAID data. So this is any SARS-CoV-2 sequence that is of a resident of New York City is uploaded to this publicly available GISAID platform. And this is the Public Health Laboratories work, so I'm just presenting it here. But every week they publish the count of variants of concern, which are listed here, and the counts lots of variants of interest, which are also listed here. This is expanding, as I'm sure you're mostly aware. The list here, it tends to expand pretty quickly, but we're listing out variants of interest and concern, and then the proportion of each variant of interest or variant of concern among all of the sequence cases that week. So things that I'll just kind of summarize quickly for you. 117, which was originally identified in the UK, is still the most predominant strain in New York City. It's about 40%. It's been roughly stable for the last 2 weeks at that. 526 was a variant originally identified in New York City. There was an MMWR a couple of weeks ago at this point now. It did grow pretty quickly, but then started to decline. It's holding at about 20–25% when you have both the E44K and the not E44K together, so that's sort of stabilized as recently. And the other thing that's probably most interesting is this B.1.617.2, which is a sublineage of B.1.617, which is originally identified in India, and you can see here we're now at 8% or so. And then the last one I'll mention is P1, which is originally in Brazil, and we're now at about 10%. So the things that we internally are keeping an eye on are P1 and 617.2, and then 117 and 526. Those are sort of the top four. And then I also want to show, this was a document that you can also find on this website. This was now quite old, and we have a draft ready to publish. We are just seeking approvals for kind of more easily accessible version of this information. But I'll just go down and show you. So what we, hopefully by next Thursday, or the very latest the Thursday after that, you should see a more interactive version of a graph like this. So instead of reading a table, you can actually read a graph like this over time, the proportion of each variant, and then also the count of each variant. So I think I'll stop there. I'd be very happy to take questions, but I know that Jane and others are also talking. So let me know if you have any questions, and thanks for your attention.
Thank you, Dr. Thompson. So next up is Dr. Zucker, who will speak about vaccination of adolescents and other COVID-19 vaccine updates.
Hi, everyone. If you want to, Allison, advance the slides. Okay, fantastic. So anyway, I'm delighted to be back today and share a number of COVID-19 vaccine updates with everyone. This data was pulled yesterday, but now we're actually over 8.4 million COVID vaccine doses administered in New York City for residents who are 18 and older. 63% of adults have received that one dose, and 54% of people are fully vaccinated. So that's really great achievement in a relatively short period of time. The data is even better for 65 plus, where 72% of people in that age group have gotten at least one dose, and 65% are fully vaccinated. Again, knowing that the burden of disease and morbidity and mortality was highest in that age group. If Corinne didn't show it, just this data is also on our website, so you can look at vaccine coverage and the sort of daily changes, overall coverage, as well as the data stratified by age, race, ethnicity, and also the geographic distribution of vaccine coverage to see which areas have high coverage and where there's low coverage. And the link to the website is on the slide. Next. The exciting news was that the Pfizer-BioNTech COVID-19 vaccine was now authorized for adolescents, and adolescent vaccination is really quite important, as adolescents, especially those who are Black or Latino are at risk for severe COVID-19 disease. And from the national data for adolescents 12 to 17, there were over 1.5 million cases of COVID, over 13,000 hospitalizations, as well as over 800 cases of multisystem inflammatory syndrome in children. And in New York City, we have a slightly different, our data is available in a different age range, but there were over 30,000 cases of COVID-19 and over 500 hospitalizations. And this is important in terms of our messaging. What we hear a lot is, well, COVID-19 wasn't severe in adolescents, but this is actually not true when you look at these numbers. And also the fact that COVID-19 is actually in the top 10 causes of death for adolescents now really speaks to the severity of illness and why it's important to prevent it. And there are also articles which have been published showing how adolescents can spread infection to others within their household and to high-risk persons, as well as in the community. So it's important to vaccinate adolescents for that reason as well. Next. On May 10th, the FDA did expand the emergency use authorization for the Pfizer vaccine to include adolescents 12 to 15. So it's now everyone 12 years of age and older. And then on May 12th, the Advisory Committee on Immunization Practices, which is CDC's advisory group, met and recommended the vaccine for this age group. Next. So just a word about the clinical trial. What they had actually done was, well, first they enrolled 2,260 adolescents, and they were assigned, randomly assigned in a 1-to-1 ratio to vaccine or placebo, and they were looking at the efficacy. Sorry, I'm just going to just step back, because what they actually had planned to do was what they call immunobridging study, which was that they would vaccinate adolescents and then look at the neutralizing antibody response, the GMTs, look at cellular immune response, and compare it to similar response in adults to say that if the response was not inferior, that one could infer that that the vaccine should be as effective in adolescents as it is in adults. And because of how much disease there was, they were actually able to demonstrate efficacy of 2 doses in preventing symptomatic laboratory confirmed COVID-19. It was 100%, although there were, overall there were really very few cases in the placebo group. Since it was a relatively small group, and there were no cases in the vaccine group. So they didn't anticipate, or I should say the study wasn't powered to find vaccine efficacy, but again, because of one, how much disease was circulating and the high efficacy of the vaccine, they were able to demonstrate this outcome. The side effects were mild to moderate, and it was similar to those that seen in people 16 to 25. So, common side effects including injection site pain, fatigue, headache, joint pain, and muscle pain. Again, as was seen with adults, that the symptoms are more common after the second dose, and there were really very few serious adverse events in either the vaccine or the placebo group, and then none of the serious adverse events that were identified were considered to be related to vaccine after FDA review. Next. So in terms of administering this vaccine, it's the same dose, so it's a 30 microgram dose, it's 0.3 ml. That's being given to the adolescents on the same schedule. So it's 1 dose, and then the second dose is given 21 days later. And there's no difference in any of the contraindications or precautions. It follows the same clinical considerations as for people 16 and older. Next. So just a word about consent. New York State had given guidance, and I know in terms of just operational considerations for some of the clinics. For people under 18, the parent or guardian must provide consent for their child to be vaccinated. The consent can be in person or by phone. It is not necessary to provide proof that they are the child's parent or guardian. For some of our city sites, they do accept proof of consent in writing. So if a 16-year-old comes with the consent in writing, that would be accepted. And then, so that would be for 16 and 17-year-olds being able to go themselves for vaccination, but minors 12 to 15 years of age must be accompanied to the vaccination site by a parent or guardian or an adult caregiver designated by the parent or guardian, and this is in the New York State guidance. And as far as proof of age, if the child does have an ID or birth certificate or other document, that's fine. But importantly, that should not be a barrier. The parent or guardian who accompanies the child can also attest to that child's age. So they don't need the proof of age in terms of an actual document if it's not available. Next. I think also what was updated in the recent clinical guidance, which is really quite important, is that it is now permissible to co-administer COVID-19 vaccine with other vaccinations, and that includes live vaccines. And this is just one, it applies to all ages. And as many of you know, and this is really across the lifespan, that both pediatric immunizations dropped off during the pandemic, as did adult vaccinations, and many people are behind on the recommended immunization schedule and behind in required vaccinations. Children were not in school. Many were not in school. They'll be going back to in-person learning in the fall. So many, both students, children, as well as other people have fallen behind, and this just gives a great opportunity to administer these other vaccines at the same time that they're getting their COVID-19 vaccines. I think one of the caveats which was listed in the clinical consideration is some other vaccines that are very reactogenic, and I think the one in particular is Shingrix, the zoster vaccine. So you would be giving 2 reactogenic vaccines. You would give them each in a different arm, and whether or not, because of the side effects, you can consider whether or not you would want to space those vaccines. But otherwise, really, to avoid any missed opportunities, we really should be co-administering other recommended vaccines at the same time as the COVID-19 vaccine. Next. So just a word about the recommendations for use of the Johnson & Johnson Janssen vaccine. This was new since the last time we had given a vaccine update, although it was some time ago now. This was back in the end of April when they were evaluating cases of thrombosis with thrombocytopenia. When ACIP met on the 27th, they did reaffirm the interim recommendation for use of this vaccine for everyone 18 years of age and older. As of May 7th, there have been 28 cases of TTS reported, and this has happened predominantly among females, and the median age is 40, but has occurred in people who are under 60 years of age. Next. So in terms of what the counseling and the important messages about use of the Janssen vaccine, what was decided by ACIP based on the data was that the benefits of vaccine, including efficacy in preventing severe illness and hospitalization, as well as death, outweighed, the potential risk of this rare side effect in terms of TTS. But it is important to educate all potential vaccine recipients, especially women under 50, about this risk and what the symptoms are. And the vaccine recipient fact sheets had been updated with this information about when people should seek care. So it is important to make sure that the vaccine recipients have this information. Next. Two other updates to the clinical considerations for using the Janssen vaccine was that if people have a history of immune-mediated syndrome with thrombosis and thrombocytopenia, that is heparin-induced thrombocytopenia, if it's been less than 90 days since the illness and the illness is completely resolved, that these individuals should be offered an mRNA vaccine. If it's more than 90 days, then any FDA-authorized vaccine can be used. And also that anyone who has risk factors or personal history of thrombosis that's not associated with thrombocytopenia, that they are not expected to have an increased risk for TTS, and they can use any authorized COVID-19 vaccine for those individuals. And this does include people who are pregnant, as well as people on hormonal contraceptives. Next. The other updates were, they sort of explicitly said that people should not be taking aspirin or another anticoagulant before any COVID-19 vaccine, and not certainly not before the Janssen vaccine to try to prevent TTS. Given the pathophysiology, aspirin would not be expected to be effective as a prophylactic. And the critical message that was distributed about TTS and sort of why there was the pause by FDA in terms of being able to educate providers is that people who have this suspected syndrome of thrombocytopenia and thrombosis after receiving the Onsen vaccine, that they should not be treated with heparin, that they need to have platelet factor 4, ELISA, the HIT assay done, and if it's negative, they can be treated with heparin, but they should not be treated with heparin until this assay result is available. Next. Staying on vaccine safety, there have been reports, and CDC did post was a report from their one of their safety committees, the Vaccine Safety Technical Work Group, about rare reports of myocarditis and pericarditis after receipt of the mRNA vaccines, both Moderna and Pfizer vaccine, and these cases are being identified. They were, this was done through the routine safety monitoring through the Vaccine Adverse Event Reporting System, and these cases are still being investigated. CDC has said that the preliminary results look like the rates of myocarditis and pericarditis appear similar to baseline rates. And these cases have occurred mostly in males and in adolescents and young adults, and so far greater than 16, and that would reflect really the duration of when 16-year-olds and older were getting vaccinated. So again, reflects the epidemiology of who's getting vaccinated. It's typically occurred several days after mRNA vaccine, and it's been more frequent after the second vaccine dose. And most cases have been mild and have responded to medical treatment and rest. So these cases are still being reported, they're being investigated, and I would expect an update from CDC on the cases in the near future. Next. So the real key messages are to consider the diagnosis of myocarditis and pericarditis when evaluating chest pain, dyspnea, or palpitations. Ask about a history of COVID-19 vaccine, and CDC has posted guidance for providers, and I will refer you there. And you know, it's really critical that people report any event to theirs, not just the serious events, because these are how these side effects and adverse events are being identified. So it really is a very important early warning system for the vaccine safety surveillance network. And there are no changes to the COVID-19 vaccination recommendations at this time for people 12 years of age and older. And CDC has also posted information for patients on their website. Next. Just this slide is to address a frequent question that we're getting, and that is about whether or not non-FDA authorized COVID-19 vaccines are acceptable and whether people should be considered vaccinated if they receive one of these vaccines outside of the US. So the current guidance is that if someone is fully vaccinated with a COVID-19 vaccine that has been authorized by the World Health Organization, that person should be considered fully vaccinated and that no additional doses of vaccine are needed at this time. If someone was vaccinated, partially vaccinated, so for example, received one dose instead of 2 doses of a full series, that individual should restart a new COVID-19 vaccine series with one of the FDA authorized vaccines. It could be either the mRNA or the Janssen vaccine. And then someone who was either fully or partially vaccinated with a vaccine that is not authorized by World Health Organization should be considered not vaccinated and should start the vaccine series with a vaccine available in the U.S. Currently, this applies to the AstraZeneca vaccine, and then two of the Chinese vaccines, Sinopharm and Sinovac, are the other three vaccines authorized by WHO that are not authorized in the U.S. And that they are reviewing other vaccine products, and there is a website on the WHO to be able to sort of track the authorization process. But those are the three at the current time. Next. I also want to mention the New York State Excelsior Pass, which again, most of you I would assume are familiar with, and this is for people to have documentation that they were vaccinated if required, for example, to attend whether it's theater or sports games, and whether, I guess that would be in terms of tickets and where people have wanted documentation of vaccination. So I would just say this is a digital record. The data that feeds into the Excelsior Pass is really, it's from the New York State Immunization Registry as well as in the citywide immunization registry. And this is sort of like stored on a smartphone, and whether it's used by businesses or venues to confirm vaccination. Adults can have their pass for their minors. One thing about the pass is it's just a green check. It does not provide actual vaccination dates, so that would not be acceptable in some settings where if vaccine was required, for example, by an employer. I will just sort of implore everyone to be very careful about how names are entered, dates of birth, phone numbers, and zip code, because the information that's used for Excelsior Pass has to match sort of exactly what is in the CIR. And so any differences in how the names are spelled, I saw someone getting vaccinated and actually said that they're looked at their date of birth and said, yes, that's it, and it was actually wrong. That person will never get an Excelsior Pass unless it's corrected. But there's just a lot of small data errors that are really causing a lot of problems for New Yorkers in terms of being able to get their pass. Someone else I recently helped, the first name field had their first name and middle name, and that prevented them from getting the pass. So it's sort of very sensitive to how the fields are entered. They also asked for the county where the vaccine provider is registered, and I think that's also been very tricky. Many of our people who are doing vaccination on behalf of the city, they may actually be registered, for example, in Manhattan, but they're doing clinics in all 5 boroughs, and there's and that's also caused a lot of problems. So we are working with the state to try to make it easier for these matches and for corrections to happen. So, please, confirm that it's all of correct vaccine information, at each step when you are registering someone and vaccinating them, whether in a clinic or in your practice or another facility. Next slide. I think what we have very exciting to the world of vaccines are a lot of anticipated developments. Both the Pfizer, BioNTech, and Moderna have applied for full FDA approval of their products. For Pfizer, it would be 16 and older, and 18 and older for Moderna. They both are going to be requesting sort of expedited review, and expedited reviews generally take 6 months. So hopefully sometime by the end of the year, we will have 2 FDA-approved products. Moderna has also applied to the FDA to extend their EUA to adolescents ages 12 to 17. That will make it easier and sort of expand the range of providers we can send vaccine to for adolescents. This is expected to happen sometime later this month. Both Pfizer and Moderna are conducting studies in children less than 12, and both of these 2 manufacturers are looking at booster doses, development of booster doses, what their impact on antibody levels are. But we have a lot of information still to come about whether how the vaccines themselves, how the booster doses will perform for variant protection, as well as information about durability of immune protection, which will affect whether or not booster doses will be needed. And also just to say, Pfizer is also conducting studies in pregnant people, and that does include following up the newborns for 6 months, looking at protection of newborns and their antibody levels. Next. We're doing well with vaccination. Vaccination has certainly slowed in recent weeks, and we really want to enlist, your help, the provider community help in getting more people vaccinated. And we want you to take every opportunity to vaccinate your patients or refer your patients. There is updated guidance from both CDC and New York State, and we've sent out a letter this morning that the wastage guidance has been, I would say, has been amended. I know we went through a time where people were really quite concerned about even wasting a dose, and there was a big push on using every dose in that vial, not opening a vial until you knew that you can use all the vaccine. But really now being in a situation of more supply than we have demand, that really you should open, even if you have one patient, you should open up a vial and not miss that opportunity. Other recent changes, which I think are great and have allowed us to expand the number of practices that we can send vaccine to, is that the Pfizer vaccine no longer can only be stored in ultra cold freezer, but the undiluted vials, frozen vials, can be transported and stored at temperatures commonly found in pharmaceutical freezers for up to 2 weeks. For people who would normally have varicella vaccine in their practice, for example, it would be the same freezer. And then thawed and undiluted vaccine can be kept in the refrigerator for up to 30 days. And that was an increase from 120 hours. So this is really terrific in terms of being able to expand where we can send the vaccine. They also now have shipments that are 450 doses instead of the 1,170 dose orders. So the 450s, are better for some of the smaller practices, and that can actually be used, half for first doses and then half for second doses, since it can be stored not in ultra cold for a total of 6 weeks, and gives you the opportunity to do both those first and second doses. And Moderna vaccine is actually shifting over to 14-dose vials. We still have a number of 10-dose vials that we're shipping out, but they will transition to only 14-dose vials. Next. Next announcement is this is New York City Youth Vaccination Week. It got kicked off yesterday, and there are a lot of activities to promote vaccination for adolescents. And this is where we also ask for your help in promoting vaccination for this age group by providing a strong recommendation to parents as well as the youth, and also sharing information. There are a number of city events, both virtual and in person, including youth vaccine block parties, virtual events, and mobile vaccination units that will be at sites where we hope to be able to vaccinate adolescents, including beaches, many iconic sites. For example, there'll be a pop-up at the aquarium. There is vaccination being offered at the American Museum of Natural History, at the Bronx Zoo, Children's Museum in Brooklyn, and many other sites. And all the list of events can be found on our website at this link. Next. In terms of vaccine resources, I think it's important that if you don't have vaccine, if you don't provide care for adolescents, that where with really all your patients as well as adolescents can be referred for vaccination. Really, there are many sites that are available now throughout the city, including both independent and chain pharmacies, federally qualified health centers, and hospitals. The NYC.gov Vax Finder has a list of all the sites, and it is searchable by vaccine brand. So if someone is looking for Pfizer, for example, for their adolescent, or if people do have brand preference, there's also information about whether there are walk-in services or the facility is ADA accessible. And people can also call the phone number 877-VAX for NYC, and the hotline will provide assistance for people to make an appointment. Important for you all is that there is a dedicated line for providers and your staff to help patients make vaccine appointments, and that would be the second prompt. If you're able to assist your patients, and especially patients who may be having trouble making their own appointment. And you can also refer a patient to the vaccine appointment hotline by filling out a short request form. And that link is on the slide. These patients should expect a call within 48 hours to have their appointment scheduled. Next. Again, what we really need from the provider community, especially to address people who may still be on the fence about whether they want to be vaccinated, is a strong recommendation. And over again, all vaccine studies, all of the surveys we've done highlight just how critical it is that a person's medical provider give a strong recommendation that they should be vaccinated with a COVID vaccine and the reasons why. Start conversations with your parents and with the parents for adolescents and patients who address their concerns, reminding parents of the benefits of vaccination, including protecting their health, preventing transmission to others, and also to enable children to resume activities that may have been stopped during the pandemic. COVID vaccines are available to everyone at no cost, and are being given to everyone living in the U.S., and that's regardless of immigration status. Providers offering vaccine are able to charge an admin fee, but no one can be turned away because they're not able to, to pay for a vaccine. Because vaccine is still being distributed at no cost to providers from the federal government. And I know that sometimes communicating with patients may be difficult, but there is guidance at the Vaccine Talks website, on the health department website, and that's just to help you with, how to have a conversation with a patient who may be hesitant to be vaccinated, and also how to answer commonly asked questions from your patients. So give you, sort of short answers to sort of, again, address people's concerns. Next. So I wanted, as I turn it over to Dr. Pooja Jani, just to really thank all of you for your efforts to get people, New Yorkers, vaccinated. Please, we're not quite at the finish line, and we need to sort of keep a focus on getting remaining New Yorkers vaccinated over, the coming weeks and through the summer. So thank you, and I'll turn it over to Dr. Jani.
All right, great. Thanks so much. So hi, everyone. I'm Pooja Jani. I'm the Health Systems Planning and Strategies lead on our agency's COVID-19 ICS response. And here I'm going to give a quick refresher on monoclonal antibodies for the treatment of COVID-19 and also provide some of the latest updates on these therapeutics. Next slide, please. So this is a schematic that highlights all the antiviral and immune modulator therapies that have been developed for COVID-19 treatment so far, and they're indicated for patients who are already hospitalized or admitted to the ICU. The advantage of monoclonal antibody therapy is that it targets patients who have been diagnosed with COVID-19 early enough in their disease process, and it's administered as an outpatient treatment, which helps to prevent ED visits and hospital and ICU admissions. Monoclonal antibodies have now been endorsed by the NIH and IDSA for outpatient treatment of high-risk patients with mild to moderate COVID-19. Also, there are no treatment options available for prevention or exposed asymptomatic infection, although several trials are being conducted. So for further information on these treatment options, you can visit the NIH treatment guidelines. Next slide. So there are two monoclonal antibody products that currently have been granted EUA status for treating mild to moderate COVID-19 in the outpatient setting. The Eli Lilly bamlanivimab and etesivimab combination product, and the Regeneron casirivimab and imdevimab cocktail. Both of these products target different regions of the spike protein on the SARS-CoV-2 virus. And then as a note, bamlanivimab monotherapy was previously approved under an EUA, but it's no longer available because the FDA recently revoked its EUA status after finding that bamlanivimab alone has reduced efficacy against the B.1.526 and other variants. So now bamlanivimab can only be used in combination with etesivimab to ensure efficacy against these variants. So etesivimab can now be ordered alone to complement on-site supplies of bamlanivimab for any treatment sites that might still have bamlanivimab monotherapy already on hand. However, new orders of bamlanivimab monotherapy have been discontinued nationwide. Bamlanivimab is authorized for use at the 700 milligram dose in combination with 1400 milligrams of etesivimab. And then casirivimab and imdevimab are only authorized at 1200 milligrams each. The optimal dosing regimen for both of these agents has not been established, but studies are still ongoing. And then in terms of clinical considerations, use of these agents requires outpatient administration via a one-time IV infusion, and they have to be given within 10 days of symptom onset. Next slide. And then this slide outlines what patients are authorized to receive monoclonal antibody treatment under the EUAs. Patients must have mild to moderate COVID-19 symptoms, have a positive direct SARS-CoV-2 viral test, be 12 years of age or older and weigh at least 88 pounds, and be at high risk for progressing to severe COVID-19 and or hospitalization. These products have shown a good safety profile with very few adverse events, and the most common ones are related to infusion-related reactions such as nausea. Next slide. And so this slide shows the eligibility criteria for use of monoclonal antibodies in both adults and pediatric patients. Recently, the FDA expanded the eligibility criteria for both monoclonal antibody products. So the expanded definition of high-risk patients has been updated by eliminating specific thresholds for defining older age, removing specific body mass index thresholds for defining overweight and obese individuals, and not limiting the definition of high risk to specific medical conditions or factors. These updates align closely with the CDC definitions in terms of what makes patients at high risk for disease progression or hospitalization. And the updates will allow individual providers to use their medical judgment when determining whether their patients are at high risk for disease progression or hospitalization. And so we encourage you to review the updated eligibility criteria in the EUA fact sheets for more information on these changes. Next slide. And then regarding monoclonal antibody treatment and vaccination, the only indication is that patients should postpone COVID-19 vaccination for 90 days after receiving monoclonal antibody treatment. And this should avoid any interference of the monoclonal antibody with the vaccine. Additionally, any eligible patient who develops COVID-19 after vaccination can still receive monoclonal antibody treatment. Next slide. And then, of course, given the rise of variants of the SARS-CoV-2 virus, we also have to consider how this impacts monoclonal antibody treatment. So the B.1.1.7 variant that was first identified in the UK is classified as a variant of concern, which means there's evidence that it has increased transmissibility and severity of disease. The B.1.526 variant that was first identified in New York City is classified as a variant of interest by the CDC because there are signs of increased transmissibility, but we don't have good information yet about severity, reinfection, or vaccine effectiveness on it. And we're also watching the P1 and B.1.351 variants that were first identified in Brazil and South Africa, respectively, because they are both variants of concern with increased transmissibility, even with previous infection. Overall, we've been seeing an increase in the variants in New York City since we've been detecting them and increasing our sequencing, and the B.1.1.7 variant remains the dominant variant of concern in New York City. Next slide. And when it comes to the use of monoclonal antibodies in the context of these SARS-CoV-2 variants, both of the monoclonal antibody products are active against the B.1.1.7 variant. However, the distribution of the an etesevimab combination product, as well as etesevimab used as a complement to existing bamlanivimab supplies, has recently been paused in 8 states because this bamlanivimab etesevimab combination is not active against the P1 and the B1351 variants, and the combined frequency of these 2 variants has increased to above 10% in these states. However, this casirivimab imdevimab product from Regeneron is likely to retain activity against these variants, and therefore it can still be used. Next slide. So although the B117 variant is still the dominant strain in New York City, we're keeping a close on these other variants because they could affect the efficacy of 1 or more monoclonal antibody treatments and may lead to a similar pause on distribution in New York City as well. Manufacturers of these products are now required to study and routinely report on variant resistance. So for example, based on the latest data reported in the EUA, we see that there is a reduced efficacy of bamlanivimab and etesevimab on the B1526 variant with the E484K mutation. And so we will have to continue monitoring this variant very closely in New York City. Next slide. And so that's a quick background plus updates on monoclonal antibodies. On this slide, we've provided some information on referring patients for monoclonal antibody treatment. The Greater New York Hospital Association Height site and the Department of Health and Human Services treatment locator both provide information on treatment sites. The Height site is a patient-facing informational website created by Greater New York that lists hospital-based monoclonal antibody treatment sites in the New York downstate region that are accepting ED walk-ins, self-referrals, and on-site testing. H&H is also able to accept patient referrals, and patients can directly contact them to be evaluated for eligibility for treatment by going to the H&H expresscare.nyc website or calling the number listed to talk to a provider and determine their eligibility for treatment. We've also included some links here on direct ordering of monoclonal antibodies and how a site can become a treatment site. And then also just as an update on reimbursement, so CMS has increased reimbursement rates for monoclonal antibody treatment effective as of May 6th. And so they're reimbursing $450 for monoclonal antibody administration in most healthcare settings and $750 when administered in the beneficiary's home. Next slide. And then at DOHMH, we've also published a Dear Colleague letter and patient information handout that have been posted on our DOHMH provider webpage. And these are being updated to reflect the latest changes in EUA eligibility criteria. So please be sure to check out these materials for further information on these monoclonal antibody therapies. And so with that, I will hand it back over to Allie.
Thank you, Dr. Shani. And so what you see in front of you now is just a page of additional resources, which includes at the top there our provider page where you can access more resources about vaccines, and where you will also be able to access these slides and the recording of this webinar by usually by tomorrow afternoon, if not the end of the day. You'll also receive those resources via email. So it does look like we have about 10 minutes for questions. I want to thank those of you who were able to participate in our polls. We will also issue a final poll in the last 5 minutes of the event. And let's see, I think we will start with some questions. We had quite a few questions for Dr. Zucker to begin. A lot of questions about myocarditis among adolescents. How soon after vaccination are people experiencing myocarditis?
Right. So it's been more commonly after the second dose of the mRNA vaccine, and it's generally been within a week after that second dose.
Okay, thank you. And do you have, I know that this was covered in the slides a bit, but any additional advice about how to speak to parents who might be afraid to vaccinate their minor children due to the myocarditis risk?
Right. So I will say CDC, the links for the information that CDC has on their website or in the slides, and so I would refer people to look at what CDC has published. They have not given a lot of details in terms of looking at, for example, median age, median sort of time after vaccination, number of cases, but I do expect, I know there is an FDA advisory group meeting next week, and so we will get some of the additional information. I'd also refer people, there was a case series which was published in Pediatrics today, and there's also some information about the Israeli series. So just to the question about talking to parents, when the myocarditis is rare and the cases have been mild, I really talk about what the impact of COVID has been on children, and it, there have been a lot of hospitalizations, there have been a lot of cases, there has been transmission. COVID-19 is now a major cause of pediatric death, and preventing infection is really critical in adolescents, and that the benefits of vaccination clearly outweigh the risk. One thing that has come up is, and I believe for the health department that we need to do, and I'll be taking it back, is that we do need specific talking points for pediatricians. We really do have, talking points for, I think, general medicine, but not something to really speak to the benefits for adolescents themselves. And some of those had been on the slide as well, just thinking about adolescents returning to school, adolescents returning to after-school programs, sports, and other programs, for reasons why you'd want to protect your adolescent.
Great, thank you. And actually on that topic of return to school, has there been any updated guidance about what rules will be required of adolescents who are fully vaccinated? Will they be, required to still wear masks in school?
Yeah, so I will defer. I know that that's been under discussion in terms of the plans for the fall and what that will mean. So there'll be further guidance coming out about that.
Thank you. We also got quite a few questions about CIR, primarily about how to enter the adolescent immunizations. Is that something that needs to be entered in CIR, or can that just be entered on an adolescent immunization record?
So everyone who's administering vaccines has to be, reporting all COVID-19 vaccinations to the citywide immunization registry, and reporting of all, childhood vaccines for 18 and younger has been required since 2005. So all of these vaccines have to be in CIR. If they're not in CIR, it will not be available to the next provider. It will not be available if the child needs an Excelsior pass. It will not be available to providers who may be providing additional vaccines in the future. So it is really critical that we have a complete reporting, for all of the COVID-19 vaccines. I mean, we really have to implore you to get all those doses in the registry. If you need help, the health department is available to provide assistance. A patient's medical record, a printout of their immunizations is fine as documentation of vaccination. It doesn't have to be a printout from the CIR. It could be a printout from your medical record. And I saw there are a lot of questions about corrections. So if you are the provider, you can actually make corrections, but we do have a provider hotline, and we do have staff who can assist in making those updates to the CIR record.
Great, thank you. And the number for that provider hotline is up on the screen, correct?
So you can get this through the provider access line. They'll transfer to our hotline.
Thank you.
Yeah, but we are available to do that. And believe me, we're getting a lot of requests for updates, as people have challenges getting their Excelsior pass.
Yes, a lot of challenges with Excelsior Pass, so that would be something also to refer providers to the access line as well, it looks like, from our questions here. Another just general question about immunizations would be, a few people are wondering if there's been any updated research about how long immunity lasts in the body from vaccination, and if it will be recommended for immunocompromised patients to, potentially get a third dose of Moderna or Pfizer in the near future.
Right. So, there's data as of 6 months now from the clinical trials, showing that there's still protection at 6 months. And people, still have, good antibody levels. And it is expected that there would be longer term protection from cellular immunity as well. But that's sort of how long the data is from the trials. And we will continue to accrue that data as people continue to be followed. There was certainly a discussion about whether booster doses will be needed. But I will say we are not seeing a lot of breakthrough infections in the U.S., and I think that that's really, really good news, and that will be part of what will, enter into the discussions by the ACIP of whether or not boosters will be needed. And ACIP is also expected to make additional recommendations for people who are immunocompromised, who may not have responded well to 2 doses of vaccine. And I know people are, looking into the data. There's not sort of systematic data. There's been some data that have been generated by some health systems, but I know that that is something that is under investigation as well.
Thank you.
So
and then
I would say stay tuned for those 2 questions for answers.
Thank you. Another few questions just about how interested practices can order smaller amounts of doses, or if they can partner with multiple practices to do so, and also if there are opportunities or if it's allowed to partner with hospitals or pharmacies to store doses if they don't have ultra cold freezers.
Right. So the good news about Pfizer is you don't need an ultra cold, right? You just need to be able to use, you have 6 weeks to use the vaccine, you have 2 weeks in the freezer, and 30 days in the, a month in the refrigerator. We are working with a number of providers to be able to split the 450 trays. The 450 trays actually come as 3 150 trays, and the health department, will help providers sort of get smaller shipments if they need, for example, only 150. We will have the Moderna EUA for 12 and older sometime later this month, and that minimum order for Moderna will be either 100 or 140 doses, and that will be another option. But we are working with a number of practices to be able to redistribute smaller amounts of vaccine so they can vaccinate their adolescents. And people who have questions, yeah.
Oh, didn't mean to interrupt if you wanted to provide an additional resource.
No, we should put the, we have, in all our communication, we have our COVID vaccine email address where people can ask for if they need help with sort of smaller shipments. And I will pull up that and put it in the chat.
Okay, thank you so much. On that line, more of a manufacturing question, but just if there has been any update, is there a possibility of potentially smaller packaging sizes for vaccines to ensure less wastage, especially, as we move into a future where we might not have large groups of people who are able to take full vials of vaccines?
Yeah, so I think that's a really great question. And unfortunately, the answer is likely no, that we shouldn't expect, sort of pre-filled syringes, for example, anytime soon. But I think that would be fantastic, right? I mean, I think it's needed, and I just think that's not quite where we are yet.
Thank you. And thank you so much, Dr. Zucker, for taking on all of these questions. It looks like we are at 2 o'clock, so we will let people go on time. We want to thank those of you who were able to complete our poll, and also just direct your attention to our next webinar, which will be Friday, June 18th. From 1 to 2 p.m., registration information will be available on our provider webpage and will also be emailed to you. An additional reminder, these slides from this presentation, as well as a recording of the presentation, will be emailed to you and uploaded to our webpage as well. So thank you again for joining us, and have a good afternoon.
Yeah, I just put the email address into the chat so people